Hello and welcome to the fourth module of the Healthcare Service Delivery chapter of the MSM Implementation Toolkit, or MSMIT, a tool that offers practical guidance for implementing comprehensive HIV and STI programs for gay, bisexual and other men who have sex with men. This training is brought to you by MSMGF, the Global Forum on Men Who Have Sex with Men and HIV. In this fourth and final module of the chapter, we present HIV service delivery approaches for MSM gay, bisexual and other men who have sex with men. After completing this module, you should have a basic understanding of 1. Service delivery and MSM. 2. Clinical approaches. 3. Community-led approaches. 4. Using information and communication technology. And 5. Safe spaces. Note that while all of the service delivery areas are important, this module focuses much of its attention and detail to community-led approaches. With these goals in mind, let's begin. Different service delivery models exist for providing a comprehensive continuum of prevention, care and treatment services to men who have sex with men, depending on the context, number of potential clients and available resources. These approaches can involve non-governmental and community-led organizations, government and private sector providers. In a large urban area that has many men who have sex with men, such as a capital city, a dedicated clinic can be developed specifically for men who have sex with men. Where developing an MSM-focused clinic is not feasible, offering dedicated service times at an existing clinic for men who have sex with men may be an alternative. In some contexts, developing hybrid models may be the best approach. For example, a government hospital might partner with an organization serving MSM in order to formally link referrals for HIV testing and counseling to services run by dedicated government staff. The community organization can complement these services with on-site follow-up and adherence support. A key principle across all of these models is that one-stop shop models reduce loss to follow-up among clients, which makes them incredibly valuable. Bundled services can include HTC, ART, and HIV-related infection treatment, distribution of condoms and condom-compatible lubricants, vaccinations, STI screening and treatment, and viral hepatitis screening. Listed here are some advantages and disadvantages of each clinical approach. Given the fact that each country and subnational setting differs, the decision of which approach is best will have to be decided with a given context in mind and with MSM community guidance. Keep in mind that services may be viewed differently by different subgroups of men who have sex with men. Some may not be comfortable going to a site that would identify them as MSM. A more acceptable alternative may be male clinics, private clinics, and gender-neutral spaces that are not identified or branded as gay, but are linked to organizations that are respectful of men who have sex with men. On the other hand, some highly visible or feminine men who have sex with men may see community-led clinics run by their peers as their only safe option. However, in more hostile environments where facilities that openly provide services to gay and other men who have sex with men are not feasible, male health clinics that include expertise in MSM health may be an alternative solution. We will continue our overview of service delivery with a detailed description of the broad categories of approach. The first we will present are clinical approaches, including mobile service delivery. Listed here are clinical service delivery elements specific to men who have sex with men that may make access easier, more acceptable, effective, and support adherence and retention. Applying service models designed for the general population directly to MSM is not as effective as approaches that take into account the unique aspects of MSM communities. These will obviously be more relevant and effective. Bear in mind that a stationary clinic base is not always the best approach to service provision for MSM. Clinical services, including STI services, HIV testing and counselling, and CD4 diagnostic services may be delivered on foot or by van at men's day health events, drop-in centres, bars and clubs, gathering and cruising areas, sex on-premise venues, house parties and community members' homes. Regardless of whether the clinics are stationary or mobile, all staff delivering clinical services should be trained and continuously updated in sensitivity towards men who have sex with men, with particular respect to ethical conduct. Presented here are core topics such training should cover. Training topics include the duty to be respectful and non-judgmental, the specific needs of subpopulations of men who have sex with men, and the absolute requirement to maintain confidentiality about any information provided during the counselling session, including the patient's engagement in same-sex behaviour. The second type of service delivery approach we will look at are community-led approaches. As mentioned previously, the method of approach is so important that it is the main focus of this module. Community-led approaches are an essential link between the community and HIV prevention, care and treatment services. They empower men who have sex with men to draw on their first-hand knowledge of vulnerability and risk to problem-solve with members of their community, strengthening access to services and making HIV prevention, care and treatment viable. Trained community members can build rapport with other men who have sex with men, understand their needs as individuals, and provide them with or link them to appropriate high-quality services on a regular basis. Community-led approaches to men who have sex with men involve building the capacity of a community-led organisation to assess the needs of the community, design high-quality services based on identified needs, and roll out these services progressively as the capabilities of the organisation grow. In most localities, the social-political context, HIV incidence, and risk behaviours among men who have sex with men will shape how services are designed. In more tolerant settings, such as some urban areas, community-led organisations may be able to be more visible about their work and hold public events and group outreach sessions. However, in much of the world, community-led organisations must operate discreetly to provide services. For more information on organisational capacity building of community-led organisations, see Chapter 6. We will now turn our attention to the shape community-led services take. Given that community outreach workers play a central role in this type of service delivery, we will begin by presenting a detailed overview of the role community outreach workers play. Secondly, we look at the specific steps involved in implementing community-led outreach. And thirdly, we will explore the concept of peer navigation and its potential to assist fellow MSM in adhering to their treatment regimens. Most community-led organisations initially build their outreach work around one-to-one and group education activities, with referrals to safe spaces, such as drop-in centres where available, or to public or private healthcare providers who are respectful of men who have sex with men. Community outreach workers typically perform a number of key functions, examples of which are listed here. They meet regularly on a one-to-one basis with MSM in an area assigned to them. A ratio of one community outreach worker to approximately 50 men who have sex with men is feasible, depending on the density of the community. Their core role is to assess the HIV prevention, care and treatment needs of men who have sex with men in their target zone and develop plans to address their needs through the program network. This typically requires knowing how many condoms and lubricants each man requires. Now that you understand the role of community outreach workers in more depth, we can turn our attention to an overview of the steps involved in implementing community-led outreach. They are to 1. Map the community and design an outreach strategy with community representatives. 2. Recruit and train community outreach workers. 3. Implement and manage outreach. And 4. Foster leadership opportunities for community outreach workers. We will go through each of these in detail, starting with the first step, mapping and program design. It is essential to understand where men who have sex with men are and how to reach them. To do this, communities must begin by mapping the location and size of the local MSM community. This is a process that must involve men who have sex with men who know and live in locations where MSM gather. Once specific locations within a coverage area have been identified, community members continue to participate by helping to assess the availability and quality of services and characteristics of the environment, as well as the relative risks and vulnerabilities of individual MSM. This process can also help identify additional men who have sex with men who can become community outreach workers. It is important to take great care when identifying locations where men who have sex with men gather, especially in jurisdictions that criminalize same-sex sexual behavior or where violence is a concern. Safeguarding data and the personal well-being of men who have sex with men at the community level must be a priority. All gathered information that is gathered should be treated confidentially. For detailed information on the steps involved in mapping and size estimation, including the need for security, please see Chapter 6. The second step in implementing community-led services is to recruit and train community outreach workers. In order to recruit successfully, a number of preparatory activities must be completed first. Organizations should 1. Develop terms of reference for the outreach worker position. 2. Develop guidelines for recruiting, retaining, assessing, and promoting. 3. Develop a training curriculum. 4. Adapt outreach tools for community outreach workers. 5. Develop a tiered training plan. And 6. Develop a career progression plan. If a new intervention is being established, these steps may seem daunting or outright impossible. In these cases, the steps can be implemented over time as the program's membership base increases. We will look at each of these steps in more detail, beginning with developing a terms of reference. The first step entailed in community outreach worker recruitment is to outline the necessary selection criteria and roles and responsibilities into a terms of reference for the job. Listed here are some suggested selection criteria. Roles can be drawn from the list presented earlier in this module. Be sure to include policies on remuneration, travel allowances, per diem, and other details as needed. The second step is to develop guidelines for recruiting, retaining, assessing, and promoting community outreach workers. Where possible, the selection process should be well publicized in the community so that all those genuinely interested in being community outreach workers can be considered. Collaborating with other programs in the state or country is a way to ensure that remuneration for community outreach workers is fair, consistent, and transparent across programs. The next step is to develop a training curriculum. Check whether an appropriate curriculum is already available for the particular outreach setting, as this will avoid energy wasted reinventing the wheel. Ideally, the curriculum should be developed and standardized at the central or regional level, but it may need to be adapted to address local language and cultural issues. There are already a number of MSM-specific training resources readily available online. The fourth step in preparing to recruit outreach workers is to adapt outreach tools for community outreach workers in collaboration with MSM community members. These may include daily and monthly tracking forms that assess each individual's risk and vulnerability factors, as well as their access to services. Outreach tools should be pictorial for community outreach workers with low literacy. Next, a tiered training plan should be developed to enhance community outreach worker skill, confidence, and leadership ability levels. This should incorporate regular training of new community outreach workers to ensure an adequate number are always available when needed. Training should also refresh and advance community outreach workers' skills and exposure to all components of the program. For example, outreach workers should be able to explain clinic procedures to men who have sex with men. The sixth step is to develop a career progression plan for community outreach workers. This is to ensure that they have the opportunity to take on greater leadership responsibility for program activities and to oversee outreach and other aspects of the program, including roles that may have previously belonged to NGO staff. The plan should include activities that enable community outreach workers to demonstrate leadership through outreach, safe space activities, and community committees. Once some core policies are in place, like the 6 we just mentioned, organizations can begin the actual work of recruiting outreach workers. A community outreach worker selection process is outlined here. In the initial stages of a program, selecting community outreach workers may occur through an informal process. The implementing organization may invite MSM who have been involved in the initial mapping and planning stages to remain involved as community outreach workers, or to identify other men who have sex with men with the potential to fulfill this role. In either case, the selection criteria listed previously should be considered. As the program matures, a more structured process for selecting new community outreach workers may be adopted, like the one presented here. Note that recruitment should take into account the continuum of vulnerability to HIV among different subnetworks of men who have sex with men, and that some will be at greater risk than others. Research indicates that men who sell sex to other men and men who seek sex with men through the internet may have high HIV prevalence compared to other networks of men who have sex with men. Community outreach workers from these high-risk subgroups should be recruited to do outreach to their peers as well. Once outreach workers are recruited, the next step is to train them. Training should take place regularly and may be done at several levels, a list of which is presented here. Training curricula should be interactive that emphasizes the value of community outreach workers to bring their own experience and initiative to their work. This means that training may be most effective when facilitated by trainers who are themselves men who have sex with men. Also note that trainers should be remunerated for their work. In addition to occurring across a range of levels, training should take up a diverse selection of topics. Here is a list of some of the topics that may be included in training at the basic level. And listed here are some possible training topics that may be included in advanced trainings for outreach workers who already have a grasp of basic concepts. Once community outreach workers are recruited and trained, the third step in establishing community-led outreach is to begin implementing and managing outreach. Outreach happens at 2 levels. The community outreach worker manages his own outreach to men who have sex with men, and program staff supervise and support the community outreach workers in their efforts. For the first level of outreach, the community outreach worker uses a multi-step prevention and case management approach for each MSM community member that is reassessed and repeated as circumstances require. Here is a list of the steps that may constitute such an approach. The second level of implementing outreach among MSM, that is, program staff supervision and support of community outreach workers, is divided into 1. Micro-planning, 2. Supervising and supporting outreach, and 3. Remunerating community outreach workers. Micro-planning gives community outreach workers the responsibility and authority to manage their own work. In this approach, community outreach workers use their knowledge of the community and the information they record during their contacts with men who have sex with men to prioritise and manage outreach. In micro-planning, community outreach workers are trained to use tools to capture data on the vulnerability and risk of each individual they serve and the services they deliver. Micro-planning tools are designed to be user-friendly, e.g. they are pictorial and can be used by people with low literacy skills. They may be adapted so that routine monitoring can be reported using a mobile phone, in addition to recording data on paper. Community outreach workers record data at each encounter with the individual MSM and aggregate them onto a weekly or monthly reporting form, or submit them electronically with the assistance of a supervisor or manager if necessary. The primary purpose of this aggregated information is to enable community outreach workers to analyse their own outreach efforts and plan their outreach according to the most urgent needs of the men who have sex with men they are serving. An outreach supervisor typically maintains the responsibility to train, motivate and monitor 5 to 20 community outreach workers. The role may be filled by a community outreach worker who has progressed into this supervisory role or by an NGO staff member until community outreach workers are trained. The outreach supervisor observes community outreach workers in their day-to-day outreach work, reviews their data on components of the service package, and may input the data into a computerized management information system if there is no dedicated data entry officer. The supervisor has weekly meetings with his group of community outreach workers, usually at the safe space or drop-in centre, to discuss high-priority individuals and any problems the community outreach workers may be encountering, and to provide informal training. Community outreach workers should always be remunerated for their work. This table shows the various activities of which community outreach workers may require remuneration. However, bear in mind that some remuneration approaches may be problematic. For example, paying community outreach workers for each individual they persuade to come to the clinic or drop-in centre for services rather than providing a fixed salary or stipend may distort demand and lead to coercion. In addition to fixed remuneration, effective incentives and evaluation-based recognition can include phone credit, non-monetary gifts, and leadership opportunities that are not linked directly to the number of men who have sex with men who are brought to the programme. Offering the chance to participate in national or international trainings and meetings where possible may also be an effective way of recognising outstanding community outreach workers. The fourth and final step in establishing community-led outreach is to foster leadership opportunities for community outreach workers. Beyond showing respect to their community outreach workers, organisations can foster leadership in the ways listed here. It is important that programmes adopt an approach from the beginning that allows community outreach workers to grow as leaders. This is because experienced community outreach workers improve the effectiveness of outreach and provide leadership in their community beyond programme services. Training and mentoring of community outreach workers should focus not only on outreach but also on strengthening their leadership. Community outreach workers with leadership skills are more likely to use critical thinking and take the initiative to reach greater numbers of men who have sex with men. Confident community outreach workers may be able to advocate with the police, assist in monitoring the programme, and can train and mentor other community outreach workers. The third component of community-led approaches is peer navigation. In order to reduce loss along the HIV prevention, care and treatment continuum, trained peer navigators can act as important mentors and guides for their peers to access and adhere to a programme. Peer navigators are community outreach workers who are knowledgeable about existing local care and treatment resources for people who are HIV positive. They may be HIV positive themselves and have first-hand experience of seeking and accessing services. Peer navigators guide new HIV programme clients from HIV counselling and testing at community sites to clinics which provide diagnostic screening and HIV treatment services. This is critical not only in context where all who test positive are required to register with a government clinic or hospital for ART, but also for supporting case management more broadly. Let's turn now to the third service delivery approach for MSM, which is using information communication technology, commonly known as ICT. Many men who have sex with men use ICT to navigate sexual, social and safe spaces through mobile phones, tablets, computers and other internet-enabled and SMS-only devices. These methods of connecting can enable them to interact anonymously if they wish with community outreach workers and peer navigators, health service providers and counsellors, and to access information and education materials and other links to the continuum of prevention, care, treatment and support. ICT can provide a broader reach and be instrumental in scaling up HIV services for men who have sex with men. ICT interventions should link the virtual to the physical, serving as a complementary link to physical spaces and people. For more detailed information, see Chapter 5. The fourth and final service delivery approach this module covers is to create safe spaces. From the outset of a program, safe spaces should be established to bring community members together. Presented here is a list of the many purposes a safe space can serve. These are typically rented, simple furnished rooms that provide community members a comfortable place to relax, rest, get information and interact. Safe spaces may also be located in the office of a community-led organisation, an implementing organisation, within a clinic or in a community member's home. They may also be virtual spaces, and many of the functions listed here can be fulfilled by online spaces. There are practical advantages to co-locating safe spaces with clinics, such as the convenience of dealing with just one landlord and the closer links between community activities and program services. Nevertheless, care should be taken to ensure that safe spaces remain a distinct community area. It is often important to separate an implementing organisation's office from the safe space and ensure that community leaders have clear responsibility for managing activities at the safe space. We will look briefly at the process for establishing a safe space. Setting up the space involves the following steps. The first is to conduct a community consultation. The consultation provides guidance on where to locate the safe space, services to be provided, staffing and service hours. Services should be available when men who have sex with men most need them. The second is to choose a suitable location. The choice of location should take into consideration not only its accessibility to men who have sex with men, but also its visibility to the public and the response from the wider non-MSM community. Care should be taken to ensure that the space is safe from intrusion by outsiders and the police. The third step is to maintain lease agreements and good relations with landlords. Maintaining a fixed location for the safe space is important to prevent disruption of services. The lease drawn up with the landlord should clearly state the duration of the agreement and clarify the hours and nature of use, and rent should be paid on time. The fourth step in setting up a safe space is to ensure it has infrastructure and is safe. The safe space should ideally have at least 2 rooms, one that can be used for one-to-one meetings or counselling, and one for community activities. The safe space should be equipped with basic equipment to handle fires and other emergencies. The fifth step is to design the space. It should be both functional and inviting. Meeting tables and chairs may be kept to one side and less in use. Couches or mattresses to sit on can make the room comfortable. Walls may be painted or decorated with art made by the community. The sixth step relates to hostile environments. In contexts where men who have sex with men are particularly discriminated against or criminalized, a dedicated space may become the target of harassment from law enforcement authorities or others, and so it may not in fact be safe. In these situations, the community and any implementing organization involved in the process should consider carefully how best to meet the needs of the community. One possibility is for an ally organization that does not serve only men who have sex with men to host the safe space. Once a safe space is opened, operational activities can commence, some examples of which are listed here. 1. Management. The program should provide resources for the space. To ensure that the community feels ownership, men who have sex with men should have the lead role in decisions about the space and its management. 2. Service promotion. To ensure men who have sex with men are aware of the safe space and its services, it may be promoted through flyers, SMS messages, and community networking. 3. House rules. These should be formulated by those using the space so that they understand what behaviour is acceptable, e.g. with regard to noise levels. This is also important so as not to disturb neighbours, as well as drug and alcohol use. 4. Relationships with neighbours. The safe space managers, including the community, should make plans to manage relationships with neighbours and those in the wider community. 5. Scheduling. If the program needs to use the safe space for program activities that involve a limited number of participants, these should be scheduled during off-peak hours so that they do not infringe upon access for the broader community of men who have sex with men. 6. Program use. Growing implementation organizations may want to use the safe space for other program activities or as offices. Efforts should be made to ensure that this does not happen or that such activities are kept to a minimum. The safe space should remain open to members of the community to use informally, even if the program is using it. And 7. Sustainability. Safe spaces can be made financially sustainable when managed by the community. For example, if the community rents out the space to the program on a limited basis. Safe spaces may offer a range of activities and services to suit the specific needs of the communities they are serving. Examples of these activities and services are listed here. Offering a wide range of services may increase community participation in the safe space and ultimately help make it more sustainable. Before moving on, please consider the questions presented in this self-check and assess your understanding of the information presented in this module. This brings us to the end of the fourth and final module of the Healthcare Service Delivery chapter of the MSMIT. To review, in this module you have been introduced to general considerations to keep in mind when conducting care and treatment service delivery for MSM, as well as a number of approaches, including clinical approaches, community-led approaches, using information and communication technology, and creating safe spaces. Congratulations, you made it! We encourage you to continue learning and explore the other chapters in this tool.